Hello, I am Dr. Anirban from Kolkata. I practice mainly diabetes, hypertension, and cardiac diseases. I am also an academic co-facilitator of Department of Family Medicine in CMC Vellore, and I work in Kolkata in Maniktala ESI Hospital in cardiology department. So we'll discuss today about some of the tidbits of hypertension. So why the treatment of hypertension is necessary, as there are so many patients who are asymptomatic. Then what is the need of treating those patients? So as we get the data, amongst the total deaths, 20% due to coronary diseases, and among those 50% related to hypertension. Among in Indian tech context, amongst the hypertensive patients, only 1/5 of the patients receive treatment. Others either don't know that they are having hypertension, or they do not take medicine, or any academic economical problem, they cannot afford to take the medicine. In a nutshell, the target BP is 140/90 in all patients. If he or she is diabetic, then we aim for a lower BP like 130/80. So if we give hypertensive patient, first we will emphasis on lifestyle monitoring for say at least 3 to 6 months. If it is not working, then we will switch to either ARB ACE inhibitor or CCB diuretics, beta blocker. There are so many options, the centrally acting antihypertensives, so many options are there. But there is a very common phenomenon which is called the white coat hypertension. When the patient come into the clinic, he is anxious and his BP may rise. But when he will go back to his home, he will be normalized and BP will come down. So the home recording is very essential, and in some of the cases, ambulatory BP monitoring and BP during the night time monitoring, those things are also very important. And in hypertensive patients, there are chance of having cardiac and kidney diseases. So monitoring of cholesterol and kidney function and potassium is very important. And some of the practical things which I face during my practice, like a patient comes with a hypertension, suppose 170/90, and I started a ACE inhibitor or ARB, and very next visit when he come back, the BP is more higher, like 190/100 or 200/100. Then we have to think that this patient might have a renal artery stenosis. Suppose a patient is having 3 or 4 antihypertensive like ACE inhibitor, ARB, diuretic, the alpha blocker, all types of antihypertensive, but still the BP is around 270/140. Then we have to check the potassium. So in that case, we have to think that patient might having cones. Cones is very common amongst the hypertensive patients. So we can switch this patient to vasodilator like CCB, and we can start with the aldactone, spironolactone, and the BP will come down. And another thing, in the CKD patients, as the kidney is not functioning well, the use of diuretic may not help. And in CKD patient, we have to know that 2.4 creatinine is the cutoff mark. After that, we cannot prescribe ACE inhibitor or ARB. Even in higher creatinine, like 1.4, 1.5, we have to be very cautious, and we should check regular creatinine and potassium. In the CKD patients, they eventually die of heart attack. So monitoring of BP and titrating the cholesterol, reaching the target cholesterol are very important. And in CKD patients, if you give the centrally acting antihypertensive or the vasodilator groups, they are more useful. So these are the some facts and figures I have discussed. It might help you. If you have some more information, want to share some new thing, you are welcome. So thank you.